I'll start
we
by...
are in public now, huh? We are in public now, huh? Okay.
Okay. So we can start now. Okay. Good evening, everybody. This is Dr. Mahmoud Salah. I'll be honored to chair this session today. We have our guest speaker, Dr. Martin. Dr. Martin, I'll be honored to introduce him. Dr. Martin is a consultant vascular surgeon and the director of vascular and thoracic surgery in Karlsruhe Clinic. He is also the president of German Wound Council, and he is one of our visiting professor in Saudi German hospital. Dr. Martin will talk about the a very interesting subject today. He will talk about the peripheral arterial disease, incidence, diagnosis, and different lines of treatment of peripheral arterial occlusive disease. We are honored also to have our panelist, Dr. Ahmed Nasif. Dr. Ahmed Nasif is a senior consultant vascular and endovascular surgeon, Leeds Teaching Hospital. He is also a council member of the Royal College of Surgeons of Edinburgh. We have also Dr. Abdurrahman Salim. He is a professor of vascular surgery, Ain Shams University, Egypt, and he is also the head of Department of Vascular Surgery in Saudi German Hospital, Cairo, Egypt. And we have Dr. Ahmed Saqr. He is a consultant vascular surgeon, and he is the head of endovascular unit in our department in the Saudi German Hospital, Jeddah, Saudi Arabia. So this is our panelist and our guest speaker. And I hope that Dr. Martin, the mic is yours. You can start your presentation.
Thank you very much. First of all, I would like to thank all of you. I hope you can hear me. For this very kind invitation and the honor to give a lecture on this subject for this audience. Now I will try to get the lectures get started. I hope you can see this. Can you see this?
No, not yet. Please share the screen.
Just a moment. Teilen. Now, is it now visible?
Yes,
now you can see it. Okay.
Yeah.
Okay. The lecture will be about 20-30 minutes, and the topic is the peripheral arterial occlusive disease, which is a somewhat underdiagnosed disease, and general recognition of the danger of this disease needs to be emphasized in the future. And I would like to show you a little bit about the worldwide incidence and the complications but the patients who suffer from this disease have, and also different lines of treatment, so as endovascular and also surgical treatment, and also some future outlooks. So the very important thing is how many people worldwide suffer from these disease. It's about 202 million people, which is a lot, and there is a little bit difference between low and middle income countries and high income countries, whatever this means. And you see it in this publication by folks here, that quite different in different regions of the world. I think your Eastern Mediterranean region is still kind of low, but it's probably growing. And you see Southeast Asia region, for instance, is the highest in the world, followed by Western Pacific and European. This is Europe. So in Europe, we have a little bit more, but I think Southeast Asian, also Japan, it's growing. And I think if the incidence of diabetes is increasing, we'll have even more people suffering with peripheral arterial disease. So what does it mean if you have peripheral arterial disease? That means that disease is a polyvascular disease, which is not focused on this one region where you detect it. For instance, 24% of patients with coronary artery disease had concomitant disease in the vascular beds. The same for cerebral vascular disease, but the patients with PAD, 61% have concomitant disease in other vascular beds. This means we need extensive diagnosis for this patient, and they also need some very special care in the treatment. If you do endovascular, it's maybe less dangerous as surgery, but if this is really true, I will show you during the presentation, especially in elderly patients. So the question is, are vascular specialists really aware of this, and how does this inform their treatment? So this is something that needs to be emphasized in the vascular community. And I think the information is really growing that these patients with lower extremity PAD, especially when we're talking about these and mainly in this talk, are at decreased risk of developing cardiac events and limb events. So that means 11% develop chronic limb ischemia if they start with claudication, and the prevalence of cardiovascular death, and this is very important, is 4 to 10 times fold higher in these patients with PAD compared without PAD. That means they have a dangerous situation concerning their long-time prognosis. So the healthcare system in some way needs to take care for this problem. So it's not just enough to solve the local problem. And you see the amputation rates also are higher, and the rates of acute limb ischemia in the future is higher in patients who have a peripheral arterial occlusive disease. Here you see this is really increasing with age in men and women equally, and you see we have more and more patients at the age of 80 years or even 85 years or older, the octogenarians, especially in our hospital, we see more and more of those, and you see if they are more than 55 years, the prevalence is higher. 20% of these patients have this arterial occlusive disease, and it really increases with age. This is a very important information. I think this didn't change since this famous Rotterdam study was done. There are not so many epidemiologic studies done in this field. So what happens to these patients if they have an asymptomatic PAD? That means you detect arterial occlusive disease by pathological pulses or brachial arm index. 4 to 10% will develop intermittent claudications, and another 20% or more will develop chronic limb ischemia or worsening claudication. And so there are two ways how this can progress. You have the limb prognosis and the general prognosis. So limb prognosis is not too bad. We can do a lot of things to keep it stable. The chronic limb ischemia can also be treated, but the all-cause mortality and the cardiovascular mortality is really high. And that means there is more than just doing the revascularization of the limb. Here you see again that the patient with a peripheral arterial disease have the worst outcomes in atherothrombotic disease as compared to myocardial infarction or stroke. Especially if you see here, the black bar is any PAD compared to cerebrovascular disease or coronary disease. They have a worse prognosis than coronary patients, and this is really important information. So now coming back to the actual talk about how do we diagnose this disease and how do we treat it. The diagnosis actually is not so complicated. I mean, this is a slide, a very basic slide, but we agreed to add a few basic slides also in this presentation. Very important is to find out by asking the patient, does he have claudication? Is it a typical or atypical claudication? It can also be some orthopedic disease mimicking claudication. So you really can find out by good questioning the patient and making exact history. And then you do the clinical examination. I will not go too much into detail of this, but sometimes you find interdigital ulcerations in diabetic patients and so on as a first sign of poor peripheral perfusion. And then, of course, which is the most important, I think every doctor in the primary care situation should also know how to do this atrial brachial index If it's less than 0.9, it's starting to be disease. If it's less than 0.5, it's critical ischemia, and you have to know about medial sclerosis when these results can be false positive too high. And of course, our standard exam, and no matter whether it's done by the vascular specialist or by the radiologist, is a duplex scan. Here you see severe profundal stenosis, and then in the end comes the imaging, the MRI, CTA, or in some cases DSA. This is just to show how it's distributed. Actually, it's 1/3 iliac, and half of it is femoral, and 15% is very low distal, and mostly in patients with diabetes. And you see here where the pulse deficit is. So if you have iliac disease, you have the problem already in the inguinal pulse. If it's femoral, you have the pulse deficit beginning in the popliteal, and so on. And this shows you also where the clinical symptoms are. If it's buttock claudications or upper leg, this should fit to the anatomical region of the occlusion. So it's always good to know what the complaints the patient has. And then we can add other tests like the treadmill test, which is standardized. We do this only in claudicants, really to find out, does he really need invasive treatment, or can he still go with conservative treatment? Then other things like oscillography, also the toe brachial index, very helpful in diabetic patients with medial sclerosis. Also the pulse velocity waveform, and some other clinical tests like the Ratchow test. Here you see an interesting automatic measure of the ABI, how we do it. This gives you a normal ABI. It's 1.1, which is normal, and it also can give you on the right leg and on the left leg the pulse wave velocity. In this case, it was a 70-year-old lady, and it was 9.3 meters per second. That means it's still normal. But if you do this as a scanning method in like 50-year-old patients, you can really find out, is he at risk of atherosclerosis? So why is the ankle brachial index so important? Because it gives you a prognosis. If it's 1, it's actually less hazard as if it gets lower. And if it's getting higher, like the medial sclerosis, the prognosis also gets worse. This is a paper which is very nice to read by the American Heart Association, how to really correctly measure the ankle brachial index. And if you take the highest value of the left arm and the highest of the lower extremity, and how you really do it correctly, because there's sometimes confusion how to do it. Then we sometimes very fast, we want to know really about the anatomical distribution of the lesions. And we, of course, are interested to see it from the aorta down to the toe. So the MRI, the magnetic resonance imaging, is very helpful because it's no exposure to X-rays, gives you a complete overview, and you don't need iodinated contrast medium. There's some caveats, like in few cases, which is actually historical, but you have to be careful. The nephrogenic systemic fibrosis, of course, the NSF, less than 3% in the case of gadolinium used as contrast medium. But actually, this is really not really clinically relevant subject, because I think the radiologists have published many papers that this is not a real danger. And of course, you have to be careful with pacemakers, defibrillators, and other metallic implants, whether to use it or not. And this is an example of a claudicant, a severe claudicant, which a patient who was a 70 years old male patient, multi-level disease. This is very typical. You have here, you see mild stenosis of both common iliacs. Then you see here subtotal occlusion of the femoral bifurcation, followed by, he has bilateral AFS occlusion, and then in addition popliteal stenosis here. The crural arteries are patent. But you see here, how many risk factors this patient has. He had already coronary bypass grafting 25 years ago. He had a myocardial infarction 14 years ago. Now he had a recent brainstem TIA. Nobody really knows why, but it was some deficit in the perfusion of the brain, and of course hyperlipemia, hypertension, and also hypothyreosis. So we have to be careful with contrast medium. So what to do with this patient? So because he had so many risk factors, we just repaired this, followed by interventional correction of this stenosis, but we did not necessarily treat this SFA stenosis because he could anyway, because of these risk factors, not use the full length of his walking distance. So what do we usually do? We try to go endovascular first. This is actually an agreement, but it's not always the right way to go, but in many cases it's the right way, and I will show you the recommendations of the European Society a little bit later, but of course we try in this high-risk patient to go for endovascular treatment, except if they have this femoral stenosis, as you just see, which is much better for surgery. But even there's some clinical randomized studies going on where we participate to compare endovascular treatment for femoral stenosis in the iliac, in the femoral bifurcation, the common femoral artery, or surgery. So we have 19-hole stents, which is frequently used. We have steel stents. We also have some stents which are treated, in this case, for instance, with silver or with other drugs-coated stents, and they can be self-expanding or balloon expanding. So the balloon expanding is mainly used in the iliacs and aortic region, and in the below the inguinal region, mostly self-expanding stents are used. There are some additional techniques for endovascular therapy, like mechanical thrombectomy has to be in your spectrum. And also the laser was very popular, is coming back. Then we have cutting balloons, very interesting thing. We have the cryoplasty or brachytherapy. So there are many ways how to reopen a femoral occlusion. This is like a very typical occlusion, not so complicated lesion, but you see here some dissection. Sometimes can be difficult to pass this. If it's not possible to pass, it's also worse to try it from retrograde. This was easy to pass and was treated with a drug-coated balloon in the end. And you see what's very important, how it looks like 6 months. So it's not enough to look at this, but you want to see the 6 months or 12 months result. Did it really help? And the discussion now is that the drug-coated balloon is not so useful in heavily calcified lesions. So best would be to do atherectomy, and then after the vascular bed was prepared, use the drug-coated balloon. The drug-coated balloons is really a hot topic in the scene at least 2 years ago, because some suspected toxicity. What does it do? It is a local inhibition of cell division from smooth muscle cells. So they're inhibited to migrate, and the protein synthesis is down-regulated. So this is the principle of a local drug application at the site of stenosis, which seems to make a lot of sense. And you can see the difference. This was one of the first studies, the impact by Dr. Tepe from Germany, actually. And he compared the drug-coated versus POBA, that means plain old balloon. You see here quite a difference in the SFA lesions, which were 8.9 centimeter, the medium length of stenosis. It was not occlusion, was stenosis. And you see a big difference here in the patency after 24 months. So everybody thought this is a really good thing, and many companies developed a lot of input in this technology. Here you can also see in another study here, a more recent study, the need for the freedom from re-intervention of the target lesion. So this is one of the typical endovascular focus. It does not say the patient needs no other treatment, but the question is a target lesion okay after the primary treatment? And you see this is even better in the use of drug-coating balloons compared to standard PTA. But then 2 years ago in the Journal of the American Heart Association, and I think all the people who are using these balloons and know about this very famous presentation by Konstantinos Katsanos, which was also presented at the different meetings like the Charing Cross. And he compared these studies and did a 2-year follow-up and a 5-year follow-up, and there was a very complicated mathematical calculation, and he found out that there is a higher mortality only in the arm of the drug-coated balloon. So nobody knew why. After 2 years, there should be difference, because the local pharmacological effect is a few days, and local concentration cannot be proven in the patient after 2 years, and so on. So there was some criticism about how these studies were pooled and whether the statistics of these studies was really correct, because the meta-analysis can only be as good as the statistics of each single study. So these results could not be confirmed in other meta-analysis. So very recently, William Gray did another meta-analysis of 7 trials, where there's no more focused comparison, only femoral lesions and same dose. And in these cases, it also in many registries, there could really be no difference could be detected. So now we have the question, is this really a relevant thing or not? So in the German healthcare regulation, it's rule that we have to inform the patient that there might be some risk for a higher death rate, but we do not see this in our own patient series, and we follow them in each hospital and also big series. So actually we can be relaxed on this, but we still have to inform the patient about this. Another question was, is there a difference between high dose and low dose? And you see here, this is a very interesting analysis, a big study here by, you see, Scheinert as a senior author, European study, where they compared drug coating balloon without bailout stenting or with bailout stenting. So see, if there's bailout stenting necessary, the result is worse, but the difference is not due to a high or low dose of the balloon. And this is one of the things which was not taken care of in the original analysis by Cazzano. So you see, there's no difference between high dose and low dose drug concentration on the balloon in the long-term result. The difference is whether bailout stenting is necessary or not. Coming a little bit to the iliac region, you see, I told you in the iliac region we prefer balloon expandable grafts, stents over self-expanding. The self-expanding is nitinol, and the other one is more bare metal stent. And also the so-called stent grafts are used, especially in task C and D lesions. For time reason, I cannot show you all the studies, but covered stents might be of advantage if you treat a lesion like this, and also especially task C or D lesions. And also there is something called CERAP, which means complete endovascular repair of aortic bifurcation, which is something surgeons originally didn't like, but there are some studies. And this is an example from our hospital where we treated this patient with a very special case, high-risk patient. He had an iliac aneurysm, not too big, 2.8 centimeters in diameter, but a heavily calcified stenosis. You could see more in the CT than here, and also some aortic stenosis calcification and dual stenosis on the other side. So we decided kissing balloons, and so we took this all care of with via bands coated. This is a stent grafts, 4 stent grafts from both groins, and this problem was solved and the aneurysm was excluded. So this was a very nice endovascular procedure. Otherwise, would be open surgery would be necessary. So the question is, the question of all questions, is endovascular therapy always preferable over bypass surgery, especially in the case of critical limb ischemia? And you see, if you do bypass surgery, there's a higher risk of cardiac events like infarction complications in the beginning, but also over time, which can reflect that these patients are maybe more ill than these ones who could be more treated by endovascular. Not so many randomized studies, but in the American registries, we can see the mortality of both bypass first, 2,000 patients, endovascular first, 1,800 patients. The mortality was not different. So if you do a good patient selection, for surgical patients or bypass, you can do it with the same low mortality as in the endovascular group. Of course, surgical site infection is very specific for bypass implantation more than for endovascular. There are some difference, also bleeding and respiratory complications. I was just would like to show you that the mortality, the peri-procedural mortality, is not really higher in bypass if you do a good selection. How is bypass? How do we do the bypasses? Of course, we try to use vein whenever possible, especially when we go below the knee. If we stay above the knee, we can use also good alloplastic grafts, because the difference in patency in the modern grafts with heparin coating or some polyester grafts or hybrid grafts will show after 2 or 3 years very late. These are the recent guidelines, the European Vascular Surgical Society guidelines and the European Society of Cardiology guidelines about how to treat chronic limb ischemia. And I would like to go through this with you briefly. So if there is chronic limb ischemia patient with open foot or wound, first you do pain control, risk factor management, wound care, and so on. And then you consider, is the patient a candidate for revascularization? Because if not, he might be candidate for amputation or conservative treatment. If he is candidate for revascularization, you do a urgent imaging, which should not take a week or 2. And then you can, of course, see, is there a way to do a revascularization? Most of the patients, I would say most of the patients, have some way to be offered revascularization. Is it short occlusion or long occlusion? If it's long occlusion, vein is available, you might consider bypass. So this is a way how you go to bypass. Is it a feasible patient for revascularization? Is it long occlusion, and do you have greater saphenous vein? If you don't have greater saphenous vein, you might consider endovascular even in long lesions. So this is a matter of debate, because some people say we do endovascular anyway. But if you have a graft and you can do a good bypass, it's a recommendation to do this bypass first. If the revascularization was successful, then it's finished and you do wound care and you can discharge the patient. If it is a failure, then it's a question, what do? You do redo surgery or endovascular correction of a surgical bypass, which is also a good way to repair it. And then if it's all impossible, then the question comes very much in the end, is there a minor or major amputation necessary? So this is like the flow chart summarizing the evidence available at 2017. This is something I would like to show you. Was a study from Switzerland, which really shows you how good the primary patency and the secondary, the primary assisted patency is for vein grafts below the knee in claudicants. So this is 120 months is 10 years. So more than 10 years follow up, you see how good this bypass work, but the patients die. So the survival rate is lower than the bypass occlusion rate. That means the patient died with open bypass graft. So this is very interesting, because it's one of the few studies with such a long follow-up showing how well the vein grafts are really working. And I'm not aware of any interventional studies about this length. And here you see a study from Professor Debus from Hamburg, the difference between vein and all the other grafts below the knee. So if you go below the knee, you should really try to use vein, greater saphenous vein, smaller saphenous vein, or arm vein. And there's some really specialists that can do from both arms, use the veins and try to make a venous graft if you go below the knee. This is a typical example of a bypass to the fibular artery. It's the only vessel left in this patient. And you see it's not a really good vessel and it has some problems here. But this procedure saved the leg of this patient. So this was a very, very good treatment for this patient. Very interesting also for the endovascular treatment is how is the fibular artery perfusion. The fibular artery is the last artery to occlude in the lower leg because it's the oldest, phylogenetically the oldest artery in the development of the body, and it's the last one to occlude. And Rico did a very nice classification, which you should really take into consideration when you treat this. Did you see here? 2 branches, patent pedal arch. This is A. B is only 1 branch open and partially patent pedal arch, not so convincing pedal arch. And very problematic is you have 1 artery. This is what we see most of the cases, and no pedal arch. The question is, it doesn't make sense to put a bypass here or put a bypass here to keep the perfusion of the foot going. So in some cases, we need to do bypasses down to the foot, pedal bypass surgery, which is can be go even further down and has some very good results if you do good patient selection. So why do we bother? Because we want to correct the diseased angiosome. So the angiosomes, there are at least 10 different classifications, shows you the distribution. What does the perineal artery, what's the area of the perineal artery, what is the perfusion area of the posterior and the anterior artery, and you can, of course, try to revascularize the vessel first, which goes to this region. However, the only advantage of this is faster wound healing, not really limb salvage, as you can see here. This is called the direct or indirect revascularization. Direct means you treat the vessel that goes to the angiosome, which is having the ulceration. And indirect is you take another artery and the other one is perfused by collaterals. And you see it's not really a difference here in this amputation-free survival, angiosome direct or indirect revascularization, which was more important factors was diabetes, the wound score, and the patent pedal arch. So this seems to be, these factors were in this study by Rico also again, more important than whether you chose the right angiosome. In the end of my presentation, I would like to show you a little bit of few words of caution of how dangerous is surgery for these patients which are multimorbid, especially the patients on dialysis if they need bypass surgery. And you see here the risks they have, the mortality rates in aortobifemoral, of course, but also in femoral popliteal, femoral distal graft, what they mostly need. if they're on dialysis or not on dialysis, and it's really except for the axillofemoral bypass, it's highly significant difference in mortality rate directly perioperatively, whereas the diabetes is giving good results. Only the difference occurs in the long-term results. So you see the more severe diabetes, like the insulin-dependent diabetes mellitus, as compared to the non-insulin dependent, there is a difference in the outcome of these patients, in this case for limb salvage. So that means the severity of diabetes gives you a long-term prognosis difference, but not immediate as compared to the patients on dialysis. And this is also a very interesting subject, the preoperative anemia. This has been studied extensively now. There's mild, moderate, or severe anemia, but not talking about renal anemia, but in patients without dialysis. And you see the different prognosis, the survival rates, depending on the rate of anemia, and this cannot be corrected by postoperative transfusion. So that's, if we have the time, we should really find out about the anemia and treat it before we do surgery. This is something is now taken into account. If you don't have to do urgent surgery, you should really take care of this problem, because it shows you how dangerous, how different the prognosis for the patients in the outcomes. So what we try to do is also what we did in Jeddah with Dr. Mahmoud a lot. It's to do hybrid therapy. That means we do local surgery and distal intervention, the intraoperative transluminal angioplasty, the YOTA, and it shows you good 5-year results and not so many studies available. Here you see typical example. You open the femoral vessel and you can go with wire down up to the aorta or down to the foot and do the intervention and do a small, very minor surgery in the groin. And this is a very effective way to treat multi-level disease. And what do the patients need as concomitant medication? This is very basic. They need aspirin, they need a statin, at least 20 milligram, not less. And now, very new, we recommend low-dose rivaroxaban. Maybe you heard of the COMPASS study, in the Voyager study, in addition to the management of all these problems. The problem is that the thrombotic risk is highest immediately after revascularization. That means the male thrombotic complications higher in the beginning. This is the Euclid trial, where there was clopidogrel ticagrelor. You see the complication rate very early. And the conclusion was in this very great study on peripheral artery disease patients, that the vascular dose plus aspirin versus aspirin alone reduced the risk of the composite endpoint, amputation, ischemia, and acute limb ischemia, major amputation, and ischemic stroke, or cardiovascular death in surgical patients or interventional patients. So there is a difference. And since we have these studies available, we try to treat the patients in addition to aspirin with this low-dose rivaroxaban, which is not more dangerous than like a heparin injection, but they take it long-term. So with this, I hope I could give you a small overview on what peripheral arterial disease is all about, how we treat it, and how the prognosis of these patients is. I think we need to distribute this knowledge to see the patients a little bit earlier, and also to focus not only on the revascularization, but to treat also the risk factors and to improve the long-term prognosis of these patients. Thank you.
Thank you very much, Dr. Martin, for this very illustrative talk. You gave us actually a nice illustration for the whole problem. Before we go to the questions of our participants, by the way, we have more than 600 participants, 600 audience now with us. So before that, we will go to the our panel, and we are lucky to have 3 eminent panels. Dr. Nasser from UK, Dr. Abdurrahman from Egypt, and Dr. Sakr from Saudi Arabia. So we may have 3 different views or 3 different opinions. So we'll start with Dr. Ahmed Nasif. Dr. Ahmed, if you have any comment or anything you want to add or to comment about the talk, Dr. Nasif, please.
Thank you, Dr. Mahmoud. Prof. Martin.
Excuse me, Dr. Nasr, may I request بس all the talking to mute his mic because we have many people. Dr. Nasr, please.
That's the price of holding popular webinars, Professor Salah. I enjoyed this very much.
Dr. Yasir, okay.
Okay, Dr. Nasr, if you can start, please.
So what is
Thank you very much indeed, Professor Salah. Martin, I enjoyed your talk very much. This is a very nice roundup of current opinion and practice. And I'm really very sorry for my laptop camera that has decided to stop. But let me say that I think we practice similarly in the UK with thorough clinical examination, history taking. You've emphasized the role of the handheld Doppler and making sure that you've got an ankle brachial pressure index reading. And I could see a couple of questions from the audience about that and how to use the handheld Doppler and so on. We rely heavily on MRA. We follow an endovascular first approach with careful selection, obviously, of both endovascular candidates as well as those who would go for surgery primarily. We reserve both drug-coated balloons as well as drug-eluting stents for those who would fail an initial intervention with ordinary balloons and stents. We use vein as our primary conduit for both above the knee popliteal segment as well as below the knee popliteal segment. We have no hesitation in open interventions for iliac disease as the primary choice for those fit candidates. And with regard to angiosomes, I think we follow similar lines unless the angiosomically relevant artery is of lesser quality than other available crural runoff vessels. With regard to our post-operative follow-up and management, we obviously use antiplatelet therapy. The COMPASS trial results has not affected that very much so far. And then they get the usual graft surveillance scans that I'm sure everybody else does. But thank you. It's been great. Thank you. I enjoyed that.
Thank you very much, Dr. Nasr.
a quick response. I think I agree and 99% on what you said. We also don't use drug-coated balloons for every initial treatment. There are some cases where we might consider to use it first, especially if we did arterectomy in the patient, then we would maybe end up with a drug-coating balloon to avoid early restenosis. So my question would be, do you see any use for drug-coating balloon as in the primary revascularization, or would you always keep it reserved for second or third intervention?
Well, thank you, Martin. We're a little bit behind in the UK with regard to atherectomy.
I don't believe it.
well, it is true. It is true. There is quite a limited experience with atherectomy, but I agree. I think if you're doing this sort of thing, then using drug-eluting technology or in a primary setting would be quite reasonable.
Mm-hmm. Thank you.
Okay, now we go to Dr. Abdurrahman. Dr. Abdurrahman, You heard the nice presentation of Dr. Martin, and we would like to hear your opinion and point of view as you are working in Egypt. If you have anything different or anything you agree or disagree with what Martin said, maybe you have different prevalence, different way of diagnosis, something like that in Egypt. So please, we are need your comment.
Thank you, Dr. Mahmoud. Let me thank Dr. Martin for his very comprehensive and precise lecture. Really, it is to the point, and I appreciate his lecture too much. Actually, Dr. Martin, I will focus on 2 points. Okay, first point is angiosome. Angiosome, I agree with you. In many cases, single tibial good run-in vessel is enough, and it can go for healing, for minor amputation, for ulcers. I agree with you 100%. But actually, in my practice, I have met cases with sometimes bounding dorsalis pedis pulse with very resisting heel ulcer. As usual, I say there is dorsalis pedis pulse. It will heal. I keep on conservative management by antibiotics, repeated cultures, and offloading everything. Okay. When I give up, I just go for posterior tibial artery revascularization. Amazingly, it heals within a couple of weeks or 1 month for maximum. Okay, this is the point I want to share with you about angiosome. My conclusion for angiosome, I agree with you in conclusion, but in some selective cases we have to go through. This is the first point. Second point regarding renal failure patients. Okay, unfortunately in Egypt we are lack of transplant program, so we are faced and stuck with many cases of end-stage renal disease on regular hemodialysis. Because also we have high prevalence of diabetes, which the main cause of renal failure in my country. Okay, so actually we go through management of many cases of chronic renal failure patients on regular hemodialysis with either arterial bypass, endovascular treatment, with the stenting, without stenting, and let me tell you, this is not. The results are not that bad as we see in the papers and in lectures and even in books. So these are my concern points.
So the first question was the angiosome and the heel ulceration.
Yes.
Yeah. I think heel ulceration is a very special situation, and in heel ulceration we always have the danger of amputation if it doesn't heal. So I think anything that will improve perfusion in this region is good for the patient, and I think in this case we would do revascularization of any vessel which we could reach, but in some cases frustrating because the heel ulceration in some cases we can do by local wound management and revascularization to bring it to a heal, or to at least to a stable situation where amputation can be avoided. This is, I think, one of the goals of this. But if the heel ulceration goes down to the bone and the calcaneus bone is involved, or there's some osteitis, I think the prognosis is really difficult. And then revascularization alone cannot really solve this problem. So I would agree with you that in this case, I think the angiosome concept is not so helpful. In general, we try to do revascularization of as many vessels as possible if you do endovascular. If you do surgery, sometimes you have to decide which vessel to revascularize. That makes it more complicated because in surgery, you choose the best vessel and then it's where you put the bypass to keep the run off and the prognosis of the bypass. And the second question was about renal dialysis and patients. Yes, we also have a big department of nephrology, and we do have to do a lot of surgery on these patients. But from a statistical point of view, their 5-year prognosis or 2 years prognosis is worse than from other patients. That means the immediate perioperative management is okay. Despite the paper I showed you, maybe that's because in other countries it's a little bit different. So we try to be very careful. We do a lot of coronary arteriograms before we do surgery in these patients, and really have to be very careful with these patients. Also management of potassium and blood sugar and all this. is important. You need good intensive care and so on. So I would not hesitate to do surgery on a renal dialysis patient. I agree absolutely with you.
I'm happy to hear so, because some lectures I have heard that renal failure and regular hemodialysis per se is indication for amputation, and don't waste time and try to go further with these patients. That's why I want the audience to know, to hear this from you. They still deserve a trial. They still deserve limb salvage trial.
Yes.
You agree? I agree with you. Yes.
They deserve an attempt for revascularization. In any case, they should be seen by a vascular specialist, and very few cases they need primary amputation, but some other way of saving the leg is in many cases possible.
So we agree together, it is not an indication per se for amputation, not because he is on hemodialysis and having critical ischemia. This will be indication for primary amputation. He should deserve a trial. We agree with together. Okay, thank you, Dr. Martin. Thank you.
Thank you very much, Abdurrahman, for this nice comment. Now we go to Saudi Arabia and Dr. Ahmed Saqr. We need your comment about the presentation of Dr. Martin, and if you have any, you agree or disagree, you have different point of view, something you need to add, and especially we need some comment about the renal failure patients or the patients on hemodialysis, because I know that we have in Saudi Arabia a lot of patients, and many of them having critical limb ischemia. And do you see any difference? What's your opinion? So please, Dr. Saqr.
Thank you, Professor Salah, for the introduction, and thanks, Professor Stork, for the rich collective data from this nice presentation. First, I have a comment about the drug-eluting technology. We had a lot of criticizing or criticism about this meta-analysis, since it been published or discussed in late 2018 in Viva, and we have some points on this issue, that in Dr. Katsanos meta-analysis, there was a small data samples about this paclitaxel. This data also had used different devices, which is not intended to be used in the same patient. It was combined, and also some of this data was missing in RCT. There was no point that showing any effect of the dose of paclitaxel over the mortality rate after 2 or 5 years, and there was no direct link between the paclitaxel, no pathophysiology between the dose of paclitaxel and the mortality rate. So that's why after this, the FDA raised some alarm about this issue, and we have, as Professor Stork said, that we have only to inform as a consent for the patient the side effect of using paclitaxel for long term as 2 or 5 years. And they also having a lot of task forces, such as in America, in USA, the Society of Vascular Surgery, or in Europe, and new meta-analysis, just as Professor Stork said, is published now about the effect of paclitaxel. So this issue is still complicated. We cannot stop using the drug-coated balloons, as we all know from a lot of RCTs that it's effective, but still the concern about mortality is not confirmed. This is my first comment. Second comment, it's a question actually to Professor Stork. In fibular bypass, what do you think about the deep venous arterialization? I think it's a new era now that a lot of people and a lot of our colleagues worldwide is using the deep venous arterialization technology, or by surgery even. What do you think about this?
You mean the venous arterialization?
Yes.
Yeah. So we don't have much experience with this. I think in some cases it can work, but I'm still not, not really absolutely convinced of this, because you get foot swelling and you get retrograde venous, better oxygenation. So the main thing is to bring more oxygen to the tissue. This is what we want. And the question is, does it really work if you do it in a venous system? There might be some cases where it works. I think the studies need to be more studies or more data available on the current situation. Maybe in patients where there is no revascularization possible, you can try. And the question for me is, for you, which vein would you choose? Like the foot vein, or where would you put the bypass to if you do this technique? This is a question which is not really answered, I think, because you might also create an AV fistula, and this could be even improving the oxygenation distal to the fistula. This is the argument against it, actually.
Would you consider still the bypass for the fibular artery if you still have a small artery disease in the foot?
I would still do it, because if the bypass has some runoff, you need a few centimeters of runoff, and then you need some network of collaterals. So what you want to do with a bypass is to improve the average blood pressure, let's say by 10 millimeter mercury. This would be even a success in some cases to just solve the leg. But the risk of failure is, of course, great. But still, if the fibular artery usually ends and then you have a collateral to the foot, and if the foot is a little bit perfused, even if the foot arch is not there, you can still give it a try. Because hard to know in advance whether it will work or not. I think it's very complicated. But this is why Rico did this classification. If it's A, it's very good. If it's B, it's medium. And if it's C, you should really think about it and know that it could fail. This is why this classification is so helpful.
Yes.
Thank you very much, Dr. Saar, for this comment. There is a question Dr. Martin raised, the very chronic question, and I would like to hear the opinion of our three panelists. Endovascular or bypass first for critical limb ischemia? I know that Dr. Martin gave us the guidelines of the European Society of Vascular Surgery, but I need to hear an opinion from UK, Egypt, and Saudi Arabia. Are everybody's following this, or somebody has different opinion? Yeah, Dr. Nasif, please.
Well, difficult question. Well, right. I think it all goes down to patient to selecting properly, and I think Martin did allude to that in his presentation. It's all about what's best for the individual patient you're treating. Endovascular first is quite attractive, obviously, is much less invasive, but if not coined to the right patient, the disaster, the outcome will be much less satisfactory. We in the UK do not believe in heroics. We do not believe in long SFA occlusion recanalization, except in very selected patients who are not particularly fit for surgery. But in general, I think we would practice like anybody else. You select your patient carefully, you see what's best for them, and you do it. So I don't think there is a solid and fast rule, or there is a black and white answer to the question, endovascular first or surgery first.
Thank you very much, Dr. Nasif. Dr. Abdurrahman, same question for you. I know that you are working in the university as well as in a private sector, Saudi General Hospital. So maybe the view is different, but we need to know what you are practicing in Egypt, or what most of our colleagues are practicing in Egypt. Endo or bypass first for critical limb ischemia?
Actually, Dr. Mahmoud, you brought us to the corner, because this way is still getting high debate, even in the university. You know, in my section in the university, we have a weekly meeting. We sit with all patients and with all angiograms, all the consultants of the department saying what we'll do the next week with all these patients. Okay, up till now, when we put an angiogram and listen about the case and at the conclusion what we will decide, 5 will say surgery and 5 will say endo first. Of course, in equivocal cases, okay, in some cases like Leriche, long-standing aorto-iliac occlusion, no doubt we will go for surgery whenever the patient is fit. But in SFA, now it came for debate because Dr. Mahmoud and Dr. Martin, you know, there is now long stents. When I stand in our discussion and say this is long SFA lesion, we should go for surgery, there is a valuable question saying, so when you will use 20 centimeter stent available in the market nowadays, and you know there is even balloons 30 centimeters in long. Actually, we went through this situation and we decided to make it in scientific research. Actually, starting endovascular first in long stenotic lesions or long occlusions in SFA is not a wrong decision. It's good decision with good results, and actually many patients survived with long stents in the SFA more than 5 years, and they are approaching to the patency of surgery, except with especially with drug-eluting balloons and drug-coating stents. So actually, this is now a very debating question. Myself, in university or in private section, I go endovascular first whenever it is possible, because it doesn't preclude surgery. You can do surgery. Still you can solve any problem because I'm vascular surgeon. So I have no problem to start with endovascular first whenever it is possible, unless the case is obvious for surgery. Like I told you, Dr. Mahmoud, aortic occlusion, long-standing iliac especially, it doesn't go with endovascular first. So I hope I answered you. We will go for endovascular first.
Thank you very much, Dr. Abdurrahman. Dr. Sabr in Saudi Arabia, and the same question, endo or bypass first for critical limb ischemia?
Actually, Professor Salah, I see this is a very, very hard question now. After just the guidelines Professor Stark said is making it easy for the decision. If you have a long lesion, thinking about the endovascular, if you have a fit patient for surgery, I will go for surgery. Still having a patient with multiple dissection for long lesion and having stenting this with a metal jacket is not a good idea. And for using a bypass as for using an endovascular option as a first option for me, you have to have first all the equipment on shelf. You have to have the devices, multiple devices to face any urgent situation, and you have to have the skill to do this endovascular. So it's not always the first option in task B, and still in fit patient for surgery, bypass surgery is a long-term good result with a good option for the patient.
Thank you very much, Dr. Ahmed. We have some questions from the audience, so we will try to answer most of them. The first question for Dr. Martin: what's the role of handheld Doppler in clinical diagnosis?
The handheld Doppler alone, without measuring the pressure, is only of limited value. You can see in acute limb ischemia whether you can find a signal in the ischemic leg. If there's no signal, you have at least a Rutherford stage 2 or 2A or 2B, a level which needs to be treated very quick. If it's still a signal there, you might have some time to do some diagnosis. For the measuring of the ABI, of course, you need an additional blood pressure management. Also, with the handheld Doppler, you can control the patency of a venous graft. For instance, an in situ graft, you can make a Doppler and hear the sound, whether it's a stenotic signal, monophasic. Some machines can show you monophasic or biphasic signal. And of course, in the carotid region, it's used very often for the primary screening about carotid stenosis. So this will be my short answer.
Okay, thank you very much. Another question for you, Martin. One of our audience is asking, so what is the best, aspirin plus low dose rivaroxaban or aspirin alone? Because he had some confusion, as you
Okay. So
so
most
I
people
want you to
okay.
elaborate more about this point.
So all patients should get aspirin. If they cannot take aspirin for some reason, like gastric ulceration, so they should take ticlopidine. But the patients need aspirin for lifelong treatment to avoid myocardial infarction and cerebral vascular disease. This is not for keeping the bypass patent. And what we want to do is we want to protect the patients from coronary or cerebral complications. And now we have the study which shows us that if you add low-dose rivaroxaban to aspirin in addition, you can even improve the result for the patient in the long term. So this is why in the COMPASS study, this was for patients with stable disease. The addition of rivaroxaban could avoid apoplex or cardiac events. And there's a second study, the Voyager study, which showed that even after an intervention or after surgery in the early phase, if there's no postoperative bleeding or post-interventional bleeding, you can start within 7 days before discharge or even earlier, directly after the treatment with rivaroxaban, so you don't have to wait until it's a stable disease. So this means actually most patients could get this we don't give it to everybody. So we give it to high-risk patients, like the one I showed you. Has coronary disease, he has carotid disease, he has a brainstem TIA, he has hypertension, so he is a multiple risk patient. These patients benefit from additional treatment of low-dose rivaroxaban. We call it the COMPASS dose. That means the low dose 2 times 2.5 milligram in addition to aspirin.
Okay. One last question about the distribution of the disease. We realize that we have different distribution in Europe from the Middle East. You know, I know that you have much more aortic or aortoiliac lesions than we have, and we have infrapopliteal disease much more than you have in Germany or UK. So am I correct or not? And do you have any explanation for this?
Very difficult question. The question is it underdiagnosed or not? Because the aortoiliac disease makes claudication and the other one makes critical ischemia. So if you see more patients with critical ischemia, you will see more below infrainguinal disease. But I think even in Europe, also in Japan, the number of patients with distal disease is increasing together with increment of diabetes and other complicated renal insufficiency. So I think the more distal the problem, the more complicated it gets, and the more endovascular is necessary. And I just want to comment on the long balloons. Of course, it's very helpful if you can place a balloon in the whole fibular artery and make a one-step dilatation with a long balloon is much better than doing 5 single PTAs in one of these vessels. So I'm not really sure about the ethnic differences, but it might be the distribution of diabetes or other diseases that influences the localization of the arterial occlusive disease. The risk factors could be different in Saudi Arabia, maybe. I'm not sure.
Thank you very much, Martin. Dr. Nassif, do you have any comment about this, that we have different distribution, Europe from the Middle East?
Well, I think I used to have the same perception, Professor Salah, but I think we're catching up. I think Europe is catching up. The prevalence of peripheral vascular disease and critical limb ischemia is on the rise with the aging population and the prevalence of diabetes. The diabetes is becoming a pandemic in its own right. So I'm not sure. And if you're saying that there isn't that much in terms of aortic disease in Egypt or Saudi, like Martin, I don't know. I don't know whether this is because it's underdiagnosed or because people are not living as long, or perhaps the profile of risk factors is not the same.
Yeah, maybe.
I'm not sure.
Okay, thank you very much, Dr. Nasif. We are very short of time. We came to the end. Dr. Abdurrahman, you have any comment? Or Dr. Saqr, you have any comment about this point before we close?
Actually, Dr. Mahmoud, you raised a very important question, because when I go for course or short attendance surgery in Europe, they have carotid and aorta in every list every day. And you know, in our region in Middle East, carotid prevalence and aortic aneurysm or aortic disease is not that much, and we are stuck with many tibial disease and SFA even. So, Dr. Martin, do you have an explanation for this?
Well, the carotid, this is a very interesting thing, because even within Europe, we have a different distribution of how much carotid we treat concerning the asymptomatic patients. Like in Denmark, nobody is treated. In the United States, it's 90%, and in Germany, it's about 60% of the carotid patients we see are asymptomatic. And the other patients, we try to catch them before they get a stroke. So we do about 30,000 procedures per year in the population of 80 million, which is not so much. So the incidence is 2 to 4% in patients over 70 years. And I'm sure if you would have a screening program in Saudi Arabia or Egypt, you might detect a few more before they get a stroke. So this is, but carotid screening is generally not recommended as opposed to PAD screening. So I don't really have an answer, but there might be regional differences in incidence. The aortic, I cannot tell you, because I think maybe we have more ladies who smoke, but aortic disease in female patients 50 years old, heavy smoker, it's quite a lot in Germany. So they get the iliac calcification and occlusive disease. And Dr. Ahmad Sakar was visiting our hospital. So it's not so many, but we see them maybe more often in big centers as in Saudi Arabia, maybe.
Thank you very much.
The Salah also has a lot of those. So I've seen them.
Thank you.
Also.
Yeah, Dr. Saqr, you have last comment?
I go with the same opinion that we are facing here an infrapopliteal disease, which is different than mentioned in the prevalence of Professor Stork presentation. We face here more than 50% of the infrapopliteal disease, more than the femoral even. And I think the main difference between the prevalence of carotid here is a screening program. We don't have that wide screening program for the carotid disease or the aortic disease, which is where we are working now upon this issue. So I think in the future it will be more screening for these two items, and I think that we will discover the cases as the Professor Stork said earlier.
Thank you very much. I think we came to the end. Again, I would like to thank Dr. Martin Stork very much, and I would like to thank our dear panelists, Dr. Ahmad Nasif, Dr. Abdurrahman Salim, and Dr. Ahmad Saqr. And we thank the Saudi German Hospital who arranged this very nice session. And I would like to thank 630 audience who are still with us to the end. So thank you very much. Thank you for everybody, and have a good night.
Thank you, everyone. Thank you, Dr. Mahmoud. Thank you.